So what do you want to discuss today?
Yeah, so I can tell you about a case I had last
Any
week.
interesting cases that you saw?
Yeah, so it's a 39-year-old male.
Mm.
He was born with bladder extrophy with epispedia. Many years ago, he came to India and had an Indiana pouch done. But now currently presented with acute renal failure with what we diagnosed by ultrasound to be kidney stones. We did a CTKUB, and there were 3 stones in the renal calyx, measuring 1.4, 1.3, and one smaller one. Yeah. So he has a history also
Both sides
of
or one
having
side?
one side, left.
Okay.
He's also had a history of percutaneous dilatation for stones before. Yeah, but the tube was, the stent that was there was removed and all that. So I would like to hear what you would say about how we should handle him.
How is his renal functions now? How much is the creat?
So creatinine was about double the normal. Yeah.
So double the normal meaning 3, 4. What is the level?
Yeah, it was about 2 point something. Just 2 point something.
Okay. And how is this pouch? It is functioning well, or is any blockage? How does he manage it?
On what? What?
No, he must have had a drainage for bladder, urine drainage after exercising the bladder. So how is he managing that?
So he catheterizes himself.
Okay, and then does he have frequent bladder washes?
Yes, he's had he has a history of having monthly washes before that was done in the hospital, but lately he's been doing them at home. Yeah.
Okay. See, the thing is, the stones are fairly common because of these urinary diversions. Because a lot of mucus is there in the pouch that they make.
Yeah.
And again, there is an infection, and these form as an nidus and frequently form stones. So one thing which he needs to do immediately is to frequently clean it. Once a month may not be enough. Usually at least once a week you need to have a wash. If they have they can either do a scopy and wash it, or with a catheter and wash, and those sort of things. Then the other thing you need to make sure is that the anastomosis they done from the ureter to the pouch, whether is there any incompetence there, or whether it's adequate, or any stricture, and those sort of things. These are things which contribute to stone formation. And again, the main, whatever be the cause, if we have adequate urine output, that will manage or flush out most of the stones. Okay, so those are the things. And for these stones, because it's already, he has these problems, these stones have to be removed. So if they have facilities for PCNL, then it is fine, you can do a PCNL.
Yeah.
Or, if it's not, it's better to open and remove the things. Even in open surgery, what we prefer is to open the pelvis and then use the scope to remove the stones instead of making any nick or incision in the kidney. Because once you open the kidney, you might be able to control the bleeding at that point. But later on, there may be secondary hemorrhage and it can bleed quite significantly from the places in nephrotomy. And of course, if we have facilities, ESWL, that is ideal because then you don't need to worry about all these things. You can just use ESWL because all these stones are small. Where do you have ESWL anywhere in your country?
Lithotripsy?
Yeah, extracorporeal.
Yeah, there is, but it's pretty expensive. It's in the private hospitals in Nairobi.
Okay.
Yeah.
What about PCNL?
Well, not locally, but it is available as well, but
In Nairobi.
more available than lithotripsy.
Okay.
Yeah.
Okay. Dr. Sely, did you see any interesting cases or anything that you'd like to discuss? Dr. Sely, you are muted. Here to unmute. Okay, then one of the things which I wanted to probably discuss today was that recently we had a patient with a bladder tumor. So it had 3 tumors. One was a very large one from the left lateral wall and about 8 centimeter by 5 centimeter by 5 centimeter. Then the 2 other tumors on the right lateral wall. This primary one was from the left wall and the other one from the right wall. So what would you do with such a patient? And hemoglobin was 3 at when the patient presented. So how would you manage these?
So let me get this right. I lost you a bit. So one-sided bladder tumor, HB of 3.
Yeah, it arises from one side, HB of 3, one large. Okay, are you able to hear now?
No, I lost you again a little bit.
Yeah.
I'm sorry.
Okay, now we're able to hear it?
Yes, completely.
Okay.
Yes, I can hear you.
Okay, so this is a lady with a bladder tumor, one large one and 2 small ones. The large one is primarily arising from the left lateral wall, but extending to the anterior wall, posterior wall. And the 2 on the right side are much smaller. And at presentation, the hemoglobin was 3 grams. And obviously, her symptom was that she had blood in the urine occasionally.
So the diagnosis is by imaging or by cystoscopy?
So, both. So she's had an ultrasound earlier, which showed the tumor, and of course, cystoscopy and a local anesthesia would confirm it.
Okay. Yeah, because
what are the factors or what are the other things you'd like to know about the patient?
Yeah. So the age.
From history.
Age.
Age is 55.
Okay. And I would like to know occupation.
Okay. Occupation is why any specific? She's a housewife, but what any specific occupation that you're interested in?
Because they are working in those factories that make certain dyes that predispose
Okay.
them.
Okay, aniline dyes. Then, okay, any other occupations that you're concerned about?
Also, of course, anywhere she has increased risk of schistosomiasis.
Okay, this is not from the area where schistosomiasis is common. Usually, it's common in areas where they have open wells.
Yeah.
Those days, especially in India, they initiate step wells where you go down and then fetch the water. But she's from an urban area where this doesn't happen.
Okay. Yeah.
There's
So.
There's one more important thing you have not asked yet.
Well,
okay, some places in India, especially nearing the Burma border and Bangladesh border, they have increased arsenic content in the water. Or sometimes the water with the high iron content, they are also more prone to this. But then there is another very common thing which we need to know. Of course, she doesn't have any of these. She doesn't have schistosomiasis. She doesn't work in leather industry. She doesn't work in aniline dyes or any of those factories. So what is another important thing which you need to ask? Dr. Celio, any ideas? Or Dr. Morris?
Yeah, and before we proceed, I want to introduce the
family history.
Huh?
Family history.
Okay, she doesn't have any family history. That's an important one. Okay, you're saying something? Huh?
Yeah, I wanted to introduce Dr. Luora.
Okay.
Yeah, who is joining us? He's from Kenya.
Okay,
maybe Dr. Luora, you can mention where you work.
I think his internet connection is poor, so you're not able to hear anything.
Yeah, but I think he's hearing us because he heard us. So I think it's okay. We can proceed.
Yeah. Yeah. Okay, so what is the one more thing that you forgotten? There's a clue. Even though she's a female, smoking.
Smoking, yes, right.
Yeah, the most important risk factor in many other, in fact, almost 100% of the patients we see with the transnational carcinoma are smokers. So you might be wondering, and in India, I don't know how it is in Kenya, women generally don't smoke, especially housewives, you don't find them smoking. But then still it's important to ask because passive smoking is almost as bad as active smoking. So if anybody in the family is smoking, so whatever you do, the cancer will keep growing. So you need to find out whether anybody in the surroundings or in the area is smoking, and they should make sure that they don't, they stay well away from the people who are smoking. Okay, then what will you do to manage?
Yeah. So I would have to optimize her by increasing her HB through transfusion.
Okay, to what level? And
yeah, 10 would be preferred.
Okay, but some will accept around 9 for giving anesthesia.
Right.
Why 10 or 9? What is the risk of? Because as long as you're waiting, she's bleeding.
Yeah.
So, I mean, why do you wait till it comes up?
No, I
Or what
wouldn't.
is or in other words, what is the risk of low hemoglobin?
So one is further bleeding, from your intervention that you might do intraoperatively.
Okay.
There's the ability to awaken from anesthesia, anesthesia complications.
See, one other thing
Yeah.
that you are worried is that even before we go to anesthesia, any hemoglobin of less than 6, they can have a cardiac arrest anytime without any provocation or without anything happening. So if that happens, whatever happens, then they will attribute it to the treatment or whatever you give. So it is unless they have a renal failure, chronic renal failure, you should not do any intervention or think of anything before the hemoglobin is above 6. And to be on the safe side, anesthesiologists will prefer a hemoglobin of about 9. And so how do you transfuse? You transfuse 4-5 units at one time or one after the other? And how long do you wait after transfusion?
Yeah, I would give packed RBCs for this patient to avoid volume overload.
Okay, packed cells. Okay.
Yeah.
Then
Yeah, and
do you give 3-4 units?
Sorry.
Let us tell you how much does it go up? How much does it go up with one pint of transfusion? Generally, the hemoglobin. Say if it is 6 and you give 1 unit of blood, how much would it go up to?
That's just by 3%. Hello? 3%.
Okay, in grams. So,
Okay, in grams.
okay, maybe about 1 to 1.5. Yeah.
About 1, yes.
Okay. So if she is 3, then you will ideally need about 4 or 5 units of blood to bring her up to a level of 9. So do you give all 4-5 units at one point, or you give with a little bit of delay?
Yeah, you give a little bit of delay in between. Yeah. So
okay, why is that? So and once that hemoglobin comes up to 9, can you immediately operate, or you want to again wait?
Well, considering the first operation I would do is a biopsy, and just cauterization of whatever will be bleeding. I wouldn't wait longer. Yeah.
Okay. The thing is, if she's continuously bleeding, as I said, one of the things which is possible to do is to do a scopy, find out where is bleeding, and you can use even Bugbee electrode to cauterize the bleeding points so that the bleeding doesn't occur. Okay, and if it is bleeding, you are not too keen to take a biopsy also at that point, because it might cause further bleeding. And if it's not significantly bleeding, and you transfuse maybe 1 or 2 units in a day, but wait for 1 or 2 days, because the transfused blood to carry oxygen and to be functional takes about 48 hours. So even if the hemoglobin reaches about 9 grams, you need to wait for about 48 hours before you do any procedures. Okay. So then, say her hemoglobin came up to 9 and you're doing a procedure. So what procedure would you do? So first thing the radiologist said is you need to biopsy. Is there anything specific about biopsy, or what are the what are the considerations during biopsy?
Yeah, I think the key thing is to make sure that biopsy is representative.
Okay, so how do you make sure it is representative?
You make sure that it's taken from the tumor, it's the core of the tumor, because obviously you could take it from.
See, it's like a seaweed or frond-like appearance. See, if this is the bladder wall, it sort of pouts out like this. Okay, so like a seaweed will grow. So do you take biopsy from here, or near the pedicle?
From the.
See, some of the biopsies you do in skin or somewhere, what the pathologists will like is they like a little bit of normal tissue with the abnormal tissue so that they can compare. So do you do this here, or it doesn't matter with TCC? And where do you biopsy? Say if it is a large tumor level, do you biopsy near the pedicle or near the tip?
I would guess near the tip.
Okay. Why? Because you want to be safe, less bleeding.
Yeah.
Okay. The blood vessels come from below in the pedicle. So during biopsy, if you injure a blood vessel, it can cause significant bleeding. Okay. And most of the places, it's fairly easy to diagnose TCC. So anywhere actually is okay. But there's only one more important consideration during biopsy. What is that?
One consideration during biopsy.
That is the most important aspect of your biopsy.
Yeah, hemostasis.
Hemostasis, anyway, you have to give. Without hemostasis, will continue to bleed. This is as far as the pathologist is concerned, as far as the report that you're looking for is concerned. Okay, you're looking at various TNM stages, this, that, and all that. But then there's one most important aspect that you need for deciding on treatment and prognosis. What is that? So what determines the prognosis or the treatment that you offer in cancer of the bladder?
The percentage of bladder involved, the depth, right?
Yeah, so which, of course, the bladder has serosa, outer muscle layer, inner muscle layer, subserosa, mucosa. So what is it that you're interested? So the main.
I thought that, I would have thought in terms of that kind of information, you could get it from an MRI.
Okay, sorry, this is one of the doctors who called because of the problem. So you want to hear what he was talking about? He had done a hysterectomy for a patient. And after 2 weeks, then she started dribbling in incontinence of urine. So what would you think of? Or what did you do? So this is a lady who had a hysterectomy and started leaking urine after 2 weeks. So what would you do, or how would you go about it? What are the things that you'll need to consider? This is the active problem that you're encountering. So what will you do? What advice will you give to this doctor?
So she had hysterectomy.
What are the possibilities?
Is it a partial hysterectomy?
No, usually they do total hysterectomy, total abdominal hysterectomy.
Okay. Maybe it's that it was hysterectomy. Yeah, that's concerning. 2 weeks.
I think still the external. Okay, now it's better. So what are we saying?
Yeah, I think that is concerning to have leak after 2 weeks.
Yeah.
Yeah.
So what are the possibilities? Where all could the leak come from?
One possibility
So after hysterectomy,
would be from the pouch.
Okay, pouch at Douglas. There'll be a VVF. So one of the sutures you take closing the vault can go through the bladder. And if it's tight and if it cuts through, or if it gets infected, then it can form a VVF. Then that's one of the common ways in which it happens. Any other way, any other place.
So, Dr. Alura, I would suggest you mute unless you're talking.
Oh,
Yeah, I suggest you mute unless you're talking. Yeah, thank you. Yeah.
So that is one possibility from the sutures that you place on the vault. So you close the anterior and posterior vaginal wall. Sometimes it can, anterior vaginal wall, if you take, it can take very thick bites. And if you're doing a continuous suture, then the area in between the sutures can become ischemic and necrose and cause a fistula. What are the other possibilities?
The other possibility is ureteral injury.
Okay, the ureter, because it, especially if there is a huge fibroid and anatomy distorted, you can have some ureteric injuries. So how do they form a fistula? So they actually bleed, form a cavity, and like an abscess, it can sort of break into two places and form a fistula. Then? And then in this case, as he described, there was a rent in the dome of the bladder, which can be just a iatrogenic injury which had occurred. So what would you do? So how do you manage this?
Well, you need to study it first.
Okay, so you need to, so what all do you do to find out where the leak or where the fistula is?
Yeah.
So the possibility, it can be in either two, only two possibilities. One is urine comes from the ureter or the bladder.
Yeah.
Okay, so how will you sort of, I mean, history-wise, how can you differentiate these two?
Well, you know, through
So
imaging. Yeah, by imaging, you could do a cystogram which would show.
See, there are only two sources.
Yeah.
History-wise. So one is from the ureter, one is from the bladder.
Yeah.
So the leak can be either from the bladder or from the ureter.
Yes.
So how would both present? So which one do you think will be more? If there is a leak from the bladder or if it is leak from the ureter?
From the bladder, it would be much more.
Hmm?
If it's from the bladder,
Okay.
there would be a lot of urine leaking and little coming through the urethra.
Okay. And which will be continuous, which will be intermittent?
From the bladder would be intermittent.
Why?
From the ureter would be more continuous.
Are you sure?
Or, well, maybe the other way around. From the bladder, it will be more continuous because it's filling up from the other side. Yeah.
See, what happens is that from the ureter, do you get injury to both the ureters or one ureter?
One.
Okay. So if it is one ureter, it's fairly easy to find out because whatever is leaking from the ureter, it'll be a fistula to the vagina, which will continuously bleed. And what happens to the bladder? It'll keep filling from the other side. So if they have, if they're able to pass urine normally and have continuous leak, it probably means that there may be injury to one of the ureters. Do you get the understand? Because the bladder is normal, so it gets filled from the other side, and the injured side will cause the leak. And generally, the leak from, as you mentioned, from the ureter, not too much, because it'll be generally a small rent, and some leak will be there, and some will go into the bladder. So it may not be a complete drainage from one full kidney. And if it is only from the bladder, the VVF is from the bladder, then again depends on where the VVF is. If it is higher up, it takes a little bit of time to fill up. But then generally, because of scarring and other things, if it is VVF, there will be only continuous leak. So you need to ask the patient whether they have normal voiding plus continuous leak. That will give you an idea. But then these are not 100% foolproof definite. So then what do you do?
You do imaging studies.
Okay. But imaging studies again are a little difficult. So it'll be quite clumsy because urine is always leaking, and you will not be able to interpret correctly. So the simplest would be to do a scopy and see. So is anything to facilitate the scopy that you do for VVF?
Pardon?
Is there anything which you can do along with the scopies to confirm the VVF or facilitate to find out where the VVF is and so on? A study which will be a little more colorful if you want to know.
Yeah, methylene blue.
Okay, so what do you do? Where do you inject the methylene blue, and what do you do?
So if you inject methylene blue into the bladder, then you can be able to see where. Yeah.
Okay, so what you do is you pack the vagina first with gauze pieces.
Yeah.
Now, number of them. Then you fill the bladder with methylene blue. Okay, if it is wet, but there's no blue color, what does it mean?
Sorry, if it is wet?
The gauze piece that you place in the vagina is wet with urine, but it's not blue in color. So what does it mean?
Coming from the ureter.
Yeah. So the leak is probably from the ureter, and there is no, usually there is a valve mechanism, so there is no methylene blue which is in the bladder going up. Okay. And again, if it is blue, then you know it is from the bladder. And depending on the where that will approximately indicate the site of the VVF. Okay. Then it can also be actually be able to visualize the VVF. So it can be a very tiny opening or it may be a large opening. So if it's a tiny opening or large opening, so when do you want to do definitive treatment? What are the minimally invasive or minimal treatment that you can try earlier? So when would you like to do a definitive surgery? And why do you want to wait?
Yeah. So I think most people wait up to 6 months and minimum 3 months. Yeah.
Okay, good. Why is that?
To allow healing of tissues.
Okay. So what is the, I think last time also we discussed, so what is the normal healing process? How much does it take?
Yeah. So it's about 80% at 6 months.
Normal healing, surgical incision.
No, that's 2 weeks.
Yes. 50% healing in about 2 weeks and 80% healing in 3 months.
Yeah.
But that is once there is no infection when it's clear. But then with the VVF, whatever healing process starts a little late. And that is the reason we wait for about 6 months. Till all the healing process is at least half or more than half complete. So that the tissue that you operate have enough vascularity. Because otherwise what happens is that in this particular patient also that because the doctor was distressed, patient was distressed, they opened and closed. And it started leaking again after a week. So if you try and do a repair before this time, only thing which will probably achieve is make the rent larger. Because more tissue will get damaged and so on. So you need to think, because it's a distressing thing, it's a difficult thing for the patient. But you have to make sure that the patient understand that it is good for them to wait sufficiently for treatment. And then, is there any other minimal invasive thing which you can do?
Maybe introducing a catheter.
Huh?
Maybe introducing a catheter of a guide wire during.
Yeah. So see, sometimes if it's a very tiny one, just drainage the bladder will heal the thing, because once you drain the bladder, the muscles instead of stretching will collapse. So it will collapses the opening and makes it tight. So that can happen before a tract forms. So the fistulas generally, in general, don't close because there is a opening and the tract epithelializes. So the vaginal epithelium, the bladder transitional epithelium, they grow and they fill the tract. And that is why once epithelium grows, the tract will not, or fistula will not close. But if you're able to recognize it quickly, just collapsing the bladder, keeping the tract or whatever it is closed, might be able to heal the fistula. So immediate post-op, within a day or something like that, you notice, or within a day, 1 or 2 days, you notice. All that you need to do is just put in a catheter and keep it draining for about a month. That should suffice. And if it is a small fistula and if a tract is already formed, you can either vaporize the epithelium using a Bugbee electrode or a guide wire and open it in a catheter or something, so that that epithelial lining is destroyed. And again, you decompress by using the bladder. So this can, we have had quite a few successful patients whom we have treated this way, smaller ones. So you go see the fistula, we burn the fistulous tract, and then put a catheter to collapse the bladder and wait for it to heal. And if it doesn't heal, then you need either, you can go through vagina or transabdominal this thing to do the VVF repair. Okay.
Question. So if you did that for a small fistula and you left a catheter, I'm imagining it to be a silicone one.
Yeah,
and then,
silicone one.
Yeah. So do you keep it 3 months or 6 months?
Usually they heal within a month. So keeping it for about 6 weeks should suffice.
Okay.
But I mean, again, it depends on the size of the fistula, how long you want to keep it. But then you don't keep the same catheter, you keep changing it. The other thing, it's a sort of double-edged sword in that if you have a foreign body, there's more chance of infection, more infestations, and those are the things. That you have to weigh against keeping the bladder collapsed. So usually the healing process, when the wounds become sticky within 48 hours to 72 hours, and 50% of the healing takes by 2 weeks. So beyond that, I mean, it's for safety, you keep for another 2 weeks. So generally 1 month should suffice. And again, as with any urology conditions, you need to maintain good diuresis so that whatever subsequent and bacteria, infected material, foreign bodies, whatever is washed away. So if you have a catheter especially, it's important to drink plenty of water and high fluid intake so that the catheter keeps draining.
Okay.
Okay, I think we'll continue the discussion on the bladder tumor patient next week because we already reached the time limit. Any other questions you like?
Probably unrelated, but could you tell us about your protocol for catheter after stricture dilatation or DVIU?
So again, see, it depends on how big is the urethrotomy you did and how carefully you're cutting it. So if you just cut only the white scar tissue, there is absolutely no bleeding. Then you need to keep it only for the area that you have cut to epithelialize, which is about 1 week per 1 mm per week. So if you, once you cut it separates to 2 centimeters, 2 millimeters, then just 1 week is enough. But if it separates to 3 millimeters, then it takes about 2 weeks for it to grow from either end. And then if you cut a little more normal tissue, you start counting after a few days because the healing process starts a little later. Okay, and then, so generally, as a rule of thumb, you can keep it for about 3 weeks for the area that you cut to epithelialize. But even then, anytime it can again start healing and scar formation and it'll contract. So to prevent further healing, you need to do self-calibration. So any cut you make in the urethra strictures, the patient needs self-calibration. At least once a day, like you're brushing your teeth, you tell them, you pass a catheter after a bath and take it out. And the catheter need not be sterile. It has to be clean. It has to be dry. Those are the 2 things that you need to follow. And make sure that they empty the bladder after self-calibration. So, actually, this is the first paper which I published in British Journal of Urology way back when I was studying. We compared a lot of patients that is the time we just started doing the self-calibration. And earlier they used to do, OPD urethral dilatations. Then we found that this is far superior to urethral dilatations, which can cause, because each time you dilate, you break and make the stricture actually spread to a larger area. and it causes pain. It can causes false passage. It causes a lot of problems. So the easiest is self-calibration, which is far more superior.
Thank you.
Okay then. We'll see you next week. Bye. Have a great day.
Bye.